Dr. Anita Slominska for her presentation entitled Losing Much More Than a Transplant, a qualitative study on the lived experience of kidney transplant failure. Anita Slominska is a postdoctoral fellow at the Research Institute of the McGill University Health Center and McGill's Institute of Health Sciences Education. She's a social scientist and a qualitative researcher investigating patient and family caregiver experience of kidney graft loss. She is interested in how patient and caregiver narratives can be integrated into evidence-based practices, contribute to the mapping out of future research directions for training and practice improvements, and guide strategies to improve patient-identified outcomes of importance. Anita is also our final Rising Star Award winner. Her award was made possible from a Canadian Institutes of Health Research Planning and Dissemination grant.
Okay, thank you so much for the opportunity to present here this afternoon some of the findings from our study. I'm just gonna, okay. So the aims of our study was really to gather patient and caregiver perspectives on the experience of kidney graft loss, and specifically to explore the impact of that loss on their lives, and also to investigate unmet healthcare needs. A little bit of background is that this is an area of research that hasn't been given a lot of attention. Even though about 50% of kidney transplant recipients will lose their graft within 10 years of transplantation. So this is a multi-phase study where we are aiming to capture multiple perspectives of all stakeholders. And we have started with a cohort of 23 recipients and 23 caregivers. We've gathered data through semi-structured narrative interviews, which we've analyzed thematically, inductively, and thematically. A little bit of information about our sample. We've had a pretty good gender distribution. However, we have an overrepresentation of white participants, also with post-secondary education. The other thing that's worth noting about our sample is that a large majority of the patients at the time of the interviews were on dialysis, with a much smaller percentage of patients who had been retransplanted. So I think that's important contextual information for understanding some of our findings also. So as I was saying, our research question was really about the impact of graft failure. And we identified 6 themes representing different types of losses that were folded into the experience of losing a transplant. And these were experienced with varying degrees of intensities based on the individual circumstances of the participants. And so we found that breaking apart and fleshing out loss as an overarching theme was a way to conceptualize and organize our findings. And it was able to also explore kind of the meaning, the broader meanings of experience. So first we have loss of control, which is defined as feeling powerless or the inevitability of graft loss and feeling unable to change or influence outcomes. So these are some representative quotes from participants. They biopsied the new kidney twice already, and then a number of MRIs and scans and just different things to see if there's an issue, and have found nothing. There's no reason for it. So they just assume it's the kidney. It just isn't working right. I mean, there's nothing I could do about the kidney that ended up in me. Others use the expression luck of the draw to describe the outcome of kidney transplant, or emphasize that the outcomes are ultimately not within their power to control. As one participant said, if it all goes south on us, it's going to be fate. Next, we found loss of control. Loss of coherence, meaning a mismatch between expectations and outcomes, or shock and confusion. And so this was experienced or revealed in experiences where patients were sure that the transplant was going to work and it didn't. And also when there was a lack of coherence between what patients were physically feeling and the knowledge that their graft is failing. One participant used the word insidious to describe the experience of graft failure, or as this participant said, I was in denial for sure about like how the way I felt and how bad I felt. I think the physicians basically they were like, okay, you're going to have to let us know when you feel ready, when you feel like you need dialysis. And even though my rational brain says, yes, it's time, or you're getting close, my emotional brain was in complete denial that this was my reality. Others expressed a kind of disassociation from the knowledge of graft failure and that it was revealed through blood work or through lab results, that it's the numbers that are bad. Additionally, others expressed how graft loss can trigger a sense of incoherence in how it's received by the wider community of family and friends. So having to tell people that it didn't work, family and friends were so optimistic when they heard I was getting a transplant, but they weren't ready to hear that it didn't work. And so you got to tell the story over and over again. And that was pretty hard. There was no one in my community that had gone through something like this before me. It was so unfamiliar, I guess, to everyone, unfamiliar and uncomfortable. Next, we have loss of certainty, referring to the many unknowns, and particularly the uncertainty surrounding the future and retransplantation. One participant said, I've always had a hard time imagining my future, like not since I was a kid, but since diagnosis. It's just so fragile that I really have a hard time imagining myself in 5 or 10 years in the future because you have no idea what your health is going to be. Another described that there were many uncertainties unfolded in kidney transplantation and likened it to a guessing game that produced uncertainties for both patients and care teams and clinicians. And in many cases, it was the possibility of retransplantation that was a profound source of uncertainty. And this could even create tension between patients and the care teams with regards to control over decision making, which comes across in this quote. And I said to the doctor, definitely, I'm going to go for a third one. And he says, well, we'll decide if you can. And I said, no, I'm telling you right now, I want a transplant. I want a third. I want another chance. And he says, well, we'll have to see. And I had a really hard time with that, not knowing, thinking that I would not be able to get another transplant. Loss of hope was our fourth theme. And what I'd like to underline about this particular theme is how loss of hope was more often associated with dialysis, whereas transplant or the possibility of another transplant was where many of the participants located a sense of hope for themselves and for their lives and their future. Some experienced loss of hope to the point that they were close to losing their will to continue with dialysis. This participant said, it's like, somebody in jail that, they decide to end it. And you say, there's no hope for me. Why am I here? And that's how I was feeling. There's a pamphlet from one of the clinics that says, choosing to stop dialysis. So I'm not the only person to do this. And many have done it. They said, that's enough. Thank you, everybody, but I'm not coming back. And I did mention it to a nurse or two. And then one of the team doctors said, listen, you really shouldn't be thinking like that. Don't think like that. There's still lots of light in the tunnel for you. And what really strikes me about this quote is the disruption in that last phrase. The saying is light at the end of the tunnel to lots of light in the tunnel. And I think this is quite revealing of how some participants conceptualize life on dialysis with no end in sight. And in many cases, loss of hope was expressed as a concern that I didn't mean to click right there, sorry, a concern that a transplant would never happen, and that the longer that a patient remains on dialysis, the more hope can wane or feel threatened. So as this caregiver said, with regards to her sister, I think she's just trudging along to go to the appointments as required, but is there a lot of hope behind that? I don't really feel that she feels there is either, and especially being put on the transplant list, there's nothing that's come up for how many years now? And this participant, like many, were in a situation being highly sensitized, and contending then with the balance between having hope and having a realistic perspective on the likelihood of finding a match. And next is loss of quality of life. And this is lifestyle changes associated with dialysis, including loss of personal freedom and loss of work and financial security. So there can be a profound financial impact to transplant loss. And for some, this loomed very large in their experience. That had practical and also mental implications. And in addition to job loss, there was also the stress of trying to maintain employment while being on dialysis. As this one patient said, when I was losing the transplant, I was worried about my job, like not being able to do it, them replacing me. When I was doing in-center dialysis, I'd leave work at 5 to get over to the hospital for 5:30. So that was stressful because now you're getting up at 7 in the morning, going to work, going straight over to dialysis, doing dialysis, coming home at 10:30, and then rinse and repeat. So that was stressful and tiring. Quality of life was also impacted by not having the energy to do things that you like to do or experience what this one participant called little joys. And so one caregiver explained with regards to his spouse, she's a very active person. So having a weight having a weight tied to you, holding you down all the time, weighed a lot on her quality of life. And she works in the yard and gardens, and a lot of things get taken away of those joys in life. And I keep saying the garden is not going anywhere. Just because we didn't use it this year doesn't mean next year it's not that we're not going to. So I'd have her plan the garden, even though we're not going to garden. So we kind of had to change things around so that you can still get some of the joys from these things without having to physically do them. And the final loss theme we noted was loss of the transplant team. And this refers to the transfer of care and the poor transition or lack of continuity between transplant and general nephrology, and how this could lead to patients feeling suddenly forgotten or abandoned. Many participants expressed that they were affected by losing the care and attention of the transplant team. One participant described her concerns about the transfer of care and her desire to maintain a relationship with the transplant team after the loss of her graft. She said, normally, when you have a failed graft, they, transplant, kind of like don't see you anymore, and you get transferred just to regular nephrology. But my nephrologist agreed to continue seeing me in the transplant clinic so that I didn't get lost in the shuffle, essentially. So I feel extremely supported by them. I mean, it's hard not to feel just like a number in the dialysis clinic, to be honest, because there's no assigned nephrologist to a patient. It's just whoever is in the clinic that week. It's literally whoever is working, and nobody knows anything about me. Oh, yeah. Okay. So we've also begun to think about practice implications to some of these findings as well. And so this would include the ways in which clinicians set expectations with patients, such as about the longevity of a graft or the risks of graft failure. Improved communication, including more empathy and more transparency, more psychosocial support, and more support for the transition to dialysis and also the pursuit of retransplantation. And as far as next steps go, we do have additional data to collect, particularly from healthcare providers. But we also have plans to disseminate patient stories. We're going to be producing a podcast, so stay tuned for that. And we also have other future plans like the development of educational resources, tools and resources that we might test in a prospective study. And then even more ambitiously, we have ideas about reconceptualizing models of care in transplant nephrology, as well as policy and system level changes. So I would just like, have many acknowledgements here, but I would like to thank all the participants in this study, first and foremost, the patients and the caregivers who had interviews with me and were willing to share their stories. we had 3 patient partners, Mirai, Lisa, and Robert, who gave very valuable input. I'd like to thank the research team at McGill, especially Dr. Shafali Sandal, my supervisor, and my other super, Ann Kinsella, and also the collaborators at 5 other transplant clinics across Canada, which has enabled our study to have a pan-Canadian focus. So if you have any questions or comments, I would be very happy to hear them.
Thank you very much, Anita.
Oh,
So
do I have to leave?
No,
Or
no,
no? Okay.
you can stay
Okay,
there.
I didn't know if that was like.
Any questions? Yes?
Thank you so much for your presentation. Understandably, your practice implications are very dedicated to the patients for now, but I'm curious, how do you plan to apply them to the actual living kidney donors? Just because I know in my research, which was focused towards people considering kidney donation, the idea that it wouldn't be successful for the patient was kind of a failure to themselves as well. And I'm just wondering how you could kind of transition that to support for them as well, so they don't necessarily feel like this procedure is hopeless, even in the event that a graft is unsuccessful.
Yeah, so it's very interesting that we have had, and I don't have the number in front of me, but we had maybe 6 or 7 living kidney donors in our caregiver cohort. And it's a very emotionally complex experience for them, but at the same time that there was recognition that, that they had done some good through their donation. But what was also noted, and I think this kind of speaks to the practice implication of not having enough support for living kidney donors, that they were not offered any psychosocial support themselves after the graft loss. And for some of our participants, this was really, really hard and really challenging, that it wasn't recognized and that there wasn't any acknowledgement that it would have a profound effect on them. But I think it was important that it is discussed and talked about, that outcomes of transplants are variable, and that there is the possibility of a transplant loss.
Thanks so much for this really great work. I was wondering if, in looking at the experiences that people talked with you about, you had thought about or might see any relationships or similarities across other conditions where there's a lot of emotional challenge and weight to this sort of notion of failure. And I was sort of thinking about kind of cancer narratives and this sort of survivorship that then makes sort of stage 4 cancers this sort of very kind of full of grief and loss and personal sort of sense of failing. And if you sort of if your team started to think about kind of situating some of that in relation to those kinds of discussions that are happening.
Yeah, I think that that's a really great point. There's a lot of investment in success in transplantation, but also in biomedicine more broadly. And these are kind of the narratives that we hear more often. These are the narratives that are, that have more publicity around them, particularly in transplantation, which I think can lead to the sense of alienation when things don't go that way. Like, the one quote that I did share in this presentation about how unfamiliar and uncomfortable that was for the family and the community, because they just weren't prepared. They didn't know how to process or even really what to do with a story like that. So yeah, I think situating it within, this these kind of broader kind of like the broader kind of ideological conditions of transplantation and biomedicine, I think is important. Okay, thank you so much.